All right. Hey, everyone. We had some AV issues today at the VA, so I'm going to go ahead and re-record this conference in a faster format. Obviously, there won't be any resident participation, but we're going to go through both of these cases step by step, just like we did today, and I'll put in any of our resident teaching points that our VA residents brought up. So, title of the conference today is Goin Green. So we've got two cases. On the left, we've got the cannabis leaf. On the right, we have the Thanos Gauntlet from the Avengers. So let's start with case number one. So case number one, a 38-year-old man presents to the ED with multiple episodes of vomiting starting yesterday. He endorses epigastric pain, denies bloody emesis, and states, when this happens, my kidneys start to fail. His vitals are notable for a heart rate of 126 and a blood pressure that's 149/114. So when the residents in conference today saw this, they saw the cannabis leaf. This immediately brought to mind a syndrome called cannabis hyperemesis syndrome. This is something that we see not infrequently at all of our hospitals. And the question was, is this cannabis hyperemesis syndrome? So our residents wanted more information. So first piece of information for this case is some additional HPI. So he's a 38-year-old man with bipolar disorder, alcohol use disorder and remission, coming in with persistent nausea and vomiting. Says for the past 2 to 3 days, he's been vomiting uncontrollably and he can't keep any fluids down. Zofran hasn't helped. He had a CT a few months ago during a similar episode, which did not show any problems. Our residents at that point astutely asked, how many showers or baths per day is this gentleman taking? And he is taking 16 baths or showers per day. And he says this is the only thing that's helping his symptoms. Now that is a lot of baths and showers, and that sort of fits right in with the cannabis hyperemesis syndrome that was brought up initially. So let's get some more data. So the next thing the residents asked about was if we had any lab work on him. And here's his lab work, a CBC, BNP, and LFTs. CBC notable for a high white count, high hemoglobin, elevated platelets. His BNP notably has a bicarb of 21, BUN of 30, creatinine of 2.74. Baseline is about 1.3. And then his total protein is up as well. Notably, his CK and lipase are normal. During the conference, then, we then talked about what sort of metabolic problem does this gentleman have? And so one of the ways to assess what metabolic problems or combination of metabolic problems is the add-back method. So when you do the add-back method, you take the patient's CO2 from the BMP, and you're going to add the patient's anion gap minus the lab anion gap, and you're going to get a number from that. So in this case, you're going to have 21 plus his anion gap, if you do the math here, is going to be 19. 19 minus our lab anion gap is 10. That's normal. And if you do that, that gives you 30. So what do we do with that number? So for the add back method, if this number is 20 to 24, that tells you that you have an additional NAGMA in addition to your anion gap acidosis. If this number is 24 to 28, you've got an isolated AGMA or anion gap metabolic acidosis. And if this number is greater than 28, you can say that you have an additional concomitant metabolic alkalosis on top of it. So for this gentleman, he's got both an anion gap metabolic acidosis as well as a metabolic alkalosis. During the conference, we asked our residents what they thought the metabolic alkalosis was from. And again, they astutely said the nausea and the vomiting and GI losses in general. So from this, it looks like he's a little bit dehydrated on his CBC, and his BMP shows evidence of an acute kidney injury and 2 separate metabolic processes. Next thing, we checked a urine drug screen, even though the patient did say that he had been using marijuana, and his urine drug screen, unsurprisingly, is positive for cannabinoids. He says he's been using edibles, he's been smoking it, he's been using more concentrated resins. He's essentially using this every day, multiple times per day. Okay, so at this point then, we pose to the residents, do you have enough information at this point to diagnose this person with cannabis hyperemesis syndrome? And there was a little bit of confusion. We diagnose this a lot, or we think people have this a lot, but the big question was, is there a diagnostic criteria for cannabis hyperemesis syndrome? And we'll talk about that in just a second. Next thing we talked about is I always think it's interesting to see where a disease or a process came from. Cannabis or cannabinoid hyperemesis syndrome is one of these illnesses or diseases that was discovered during our lifetimes. And the first mention of it was from Australia back in 2004. So this was a study in the the journal Gut, in the aptly named stomach section, cannabinoid hyperemesis, cyclical hyperemesis in association with chronic cannabis use. And so I've highlighted the methods here, but essentially this one Dr. Allen looked at 10 patients who had a cyclic vomiting illness and were chronic cannabis users, and basically looked to see what characteristics they shared, what was different, et cetera. So one of the other notable things that came out of this study was this group was the first one to describe what we now sort of all associate with cannabis hyperemesis syndrome. And here was the first ever description in the literature. They said that a novel finding was compulsive bathing or washing in 9 of the 10 patients. So 90% of the patients in this first study showed the evidence of the compulsive bathing, so the showers, the baths that they do throughout the day. And in conclusion, the authors of this study, this is a lot of text here, but in conclusion, the authors said that all 10 patients described in the paper were cyclic vomiters and chronic cannabis users. And symptoms resolved in 7 patients with cannabis abstention. And then when they rechallenged themselves, it returned. And so overall, the authors here felt pretty confident in saying that they had identified a syndrome, which we now know as cannabis hyperemesis syndrome. But that doesn't really get us any closer to figuring out whether what the diagnostic criteria are or how we can sort of identify this in the hospital. And so we fast forward to 2017, and a group in Denver, actually out of Denver Health, ran a really cool systematic review where they looked at all the published data that had come out so far on cannabinoid hyperemesis syndrome. So we zoom in here. This is looking at frequency of cannabis use among people diagnosed with this. And you can see that almost everyone, 98% of people, either used weekly, daily, or greater than daily. And so in order to have cannabinoid hyperemesis syndrome, you have to use a cannabis product essentially at least weekly. The next thing they looked at was all the published studies, what were some of the most prominent characteristics. And of those, the most prominent characteristics were regular cannabis use, severe nausea, vomiting, cyclic pattern, resolution when they stopped, and then, like we just discussed, compulsive hot baths with symptom relief. So from that, we can sort of come away with a set of diagnostic criteria. So cannabis hyperemesis syndrome, what are our diagnostic criteria sort of taken directly from this study? So for our diagnostic criteria, you have to use cannabis at least weekly for greater than 1 year. You have to have severe nausea and vomiting in a cyclic pattern. You have to have abdominal pain. You have to have resolution if you stop cannabis, and then compulsive hot bath or showers with symptom relief. The next question we asked the residents, and this is also sort of a matter of discussion in the broader toxicology community, is why exactly does this compulsive bathing happen? And there's really 2 big theories. One theory is it has something to do with the hypothalamus. So chronic cannabis may change our hypothalamus, and something about a hot shower resets our hypothalamus, makes these people feel better. Another theory is something called the steal phenomenon. And so in this phenomenon, we know that in rats and mice, cannabis use causes splanchnic vasodilation. And the theory is that if a person with cannabis hyperemesis syndrome gets in the shower, a hot shower causes peripheral vasodilation and shunts blood away from the splanchnic vasculature. And so if the physiology here is increased blood flow to the splanchnic vasculature is causing pain, nausea, and vomiting, shunting blood away from that by getting in the shower would be beneficial. And because this is such a chronic phenomenon, it's also a learned behavior. And so this sort of becomes a compulsion or something that patients do instinctually. So that's how we diagnose it. How do we treat it? And during conference, our residents knew these answers because this is something we see pretty regularly. But there's really 3 big treatments. Number 1, and most importantly, is cannabis cessation, which is sort of the most difficult, convincing someone that the cannabis is causing their current symptoms. Next is haloperidol or droperidol, another form of a D2 blocker. The reasoning here is that the pathways, the dopaminergic pathway and the cannabinoid receptor pathway might have some overlap. And so giving someone a dopaminergic blockade agent will help. And then last is topical capsaicin. And there's a bunch of theories why this works, but essentially there's something called the vanilloid receptor, which has some overlap with the cannabinoid receptor. And by giving someone topical capsaicin, you can help with some of the symptoms. Notably, cannabis hyperemesis syndrome is pretty refractory to our normal antiemetics, so Zofran, prochlorperazine, et cetera. But the big thing to remember here is that cannabis cessation is going to be our tried and true treatment. So for case 1 here, if we zoom back out, we basically ran through a typical presentation of cannabis hyperemesis syndrome. We talked about diagnostic criteria and then how we can treat it. All right, so case number 1 is going to be cannabis hyperemesis syndrome. So then case number 2 here, the Thanos Gauntlet. We scroll over and we've got a chief complaint of fatigue myalgia for 1 week, a 34-year-old woman with a history of obesity, BMI of 42, type 2 diabetes, coming with 1 week of cough, fevers, dyspnea, fatigue, and myalgias. She has family members in the household that have been sick with similar symptoms. Ultimately, this woman is found to be COVID positive. Sorry about that. All right, so ultimately this woman is found to be COVID positive. So at this point, the residents also didn't know what time of year this was, but there's going to be a context clue here in just a second. So she's admitted to the hospital. Here is her initial chest x-ray. And you can see that it looks pretty bad. She's got bilateral alveolar infiltrates, clearly has evidence of developing ARDS. So she's admitted to the hospital. On day 1, admitted to the ward, and she started on hydroxychloroquine. At this point, the residents were sort of astutely aware that this was back in April of 2020. So this was an older case because we are obviously no longer using hydroxychloroquine. Day 4, she's transferred to the ICU with increasing dyspnea and worsening hypoxemia, now requiring heated high flow at 80% and 60 liters per minute. Day 5, she's intubated and lines and tubes are placed. Day 6, she's prone, paralyzed, and inhaled pulmonary vasodilators are started. And day 7, she started on CRT for anuric renal failure. So the case really picked up on day 8. So on day 8, I asked that the residents sort of put themselves in place of they're coming onto a new service. You don't know too much about this patient. You just got the sign out email and a nurse calls you early in the morning with the following message. So nurse calls early in the morning to say the Levofed requirement has increased from 0.05 micrograms per kilogram per minute to 0.3 micrograms per kilogram per minute over the past 4 hours. Per the nurse, there's no difficulties with CRT, no changes to the ventilator, and no other physical exam changes. So at this point, I asked the residents to take about 30 seconds to a minute and think about how they would approach this, right? You've got about 30 seconds to a minute as you walk to the room. So what are you going to knock out when you go in the room? What do you want to know, et cetera? And the residents did a really nice job here. Obviously, they said they were going to ask for a full set of vitals. They were going to do an exam. They wanted to know if the person was going to be hot or cold to really clarify the shock state. They then wanted to make sure there was no mechanical issues going on. And by that, they were referring to, are all the lines connected? Is the CRT running appropriately? Has anything changed there? They then wanted to know if there were any changes to the vent, for instance, things like a tension pneumothorax. And finally, they wanted to know medications. So specifically, had anything changed recently with sedation? And the 2 sedatives they were most concerned about were propofol and Precedex. So both meds that have been associated with hypotension. So the first piece of information that we gave the residents at this point was a medication list. Sorry, the first actually we gave them was a physical exam. So as you can see, this person's afebrile, heart rate is 74. Blood pressure is 112/43 on, like we said, 0.3 of norepinephrine. Breathing 28 times per minute, setting 96%. Their vent settings are over here, APV, CMB, 428, 70%, and 16. And these settings have been the same for roughly 3 days. On exam, this person is intubated, sedated, and proned. So big stuff there. They're regular in rhythm, pulses are okay. As we said, they're intubated, they are sedated and paralyzed, and the Foley's in place, but no urine is draining. Remember, this person is an anuric renal failure. So the next thing we gave the residents was a med list. So here's the med list. It's split up into continuous infusions and other medications. So continuous infusions, they were on norepinephrine at 0.3, vasopressin at 0.04, hydromorphone at 1.5, and propofol at 70 micrograms per kilogram per minute, as well as ketamine and rocuronium. They were on some antibiotics and prophylactic meds. And so at this point, I asked the residents sort of what's abnormal about this continuous infusion list. And almost all of them immediately pointed out that propofol at 70 micrograms per kilogram per minute seems like a large dose. And then a couple of our second and third year residents correctly pointed out that in our hospitals, we typically stay less than 50 micrograms per kilogram per minute as long as we are ordering within our sedation and analgesia order sets. So EPIC and CPRS actually prevent us from ordering more than 50 micrograms per kilogram per minute. So the residents were rightly concerned about the amount of propofol going in. The next thing that happened was I showed them some labs. So we had a hemoglobin 11.4, and notably when you look at this BMP here, sodium is 132, bicarb has dropped to 19 from 25, creatinine is stable at 3.22, the person has renal failure, and the lactate had increased from 0.8 to 3.1. So all of these changes had occurred in the last hour, or sorry, the last 4 to 5 hours. So to really hammer home the add back method that we had talked about in case 1. So if you take the bicarb here, which is 19, and you add the patient's anion gap, which if we do the math again, which I have to do in my head here, is about 17. So 17 minus 10, you end up getting 26. So if we go back to our add back method, because this number is less than 28, you can say pretty confidently this person has a single anion gap metabolic acidosis, likely from the lactic acidosis. In addition, just to kind of round out the workup here, a chest x-ray was also obtained. And this chest x-ray showed a clear worsening of the patient's ARDS. So now, fluffed out bilateral alveolar infiltrates. There's a couple lines in place, but no tension pneumothorax or anything like that. And then in addition to all of this, while the labs are returning, you see the following on telemetry. So here's a rhythm strip. So I showed this to the residents, and the residents immediately said, this looks a lot like a non-sustained VT. So if we zoom out here, between the continuous infusion, the hypotension, the extra propofol, the anion gap metabolic acidosis, and the arrhythmia, our residents rightly became concerned that could this person have a propofol infusion syndrome? And lo and behold, this person actually did have propofol infusion syndrome. So how do we diagnose propofol infusion syndrome? And that was sort of what we talked about for the remainder of the case. So the first thing we did was we actually went and looked at propofol. So here is a cartoon of propofol. So what is the mechanism of propofol? So it's a GABA agonist. And the really nice thing about propofol is its onset and duration is very fast. So it starts to work in less than 1 minute, and it typically wears off in about 3 to 10 minutes. And the reason it works so fast is it's very lipophilic, and it crosses the blood-brain barrier pretty easily. So it's a really good sedative. But the question I actually didn't know before this conference, which we talked about next, is why do we use propofol as compared to the benzodiazepines or Precedex or something like that? And so to answer that question, we pulled up a study from the American Journal of Respiratory and Critical Care Medicine in 2014 by Leonardo et al. And this was a really interesting study where they essentially looked at benzodiazepines and propofol in patients who were intubated in the ICU. And what they were trying to find from this was there a mortality difference? Was there a difference in days on the ventilator? Was there a difference in days till ICU discharge between benzodiazepines and propofol? Because up until this point, the sort of general practice was to sedate people with benzos in the ICU. And notably what they found was for the propofol groups, there was a lower relative risk of mortality for propofol compared to midazolam and propofol compared to lorazepam. And if we scroll down here to the diagrams, you can see that there is a huge gulf in both charts between propofol and midazolam and propofol and lorazepam. So overall, propofol was associated with a lower mortality, a shorter time to ICU discharge, and decreased time on ventilator, which are all objectively really good things. So this study in 2014 was sort of a landmark trial in the ICU because it really gave us data that we should transition away from benzodiazepines and use propofol for sedation. You know, that's not to say that propofol is without its adverse effects. And of course, one of those adverse effects is the propofol infusion syndrome. So the next thing we talked about was what is the propofol infusion syndrome? And so to answer that question, we pulled up this diagram. So the propofol infusion syndrome. So why does propofol infusion syndrome happen? And sort of the underlying mechanism is mitochondrial dysfunction. So it knocks out the mitochondria and causes downstream effects in essentially all organs of the body. So it works in the heart, causes heart failure, VT, but it also causes bradyarrhythmias, asystole, and the Brugada pattern. It causes hypotension, can cause kidney injury and green urine, can cause rhabdo, causes metabolic acidosis, and it increases the triglycerides count. And that's the propofol infusion syndrome. The next question we pose to the residents is, of these symptoms, what are the most common or what are the most frequent? And so from a couple systematic reviews, we can put some numbers to some of these things. So the most common symptom is actually metabolic acidosis. So about 77% of patients with the propofol infusion syndrome will have metabolic acidosis. The next most common is going to be arrhythmias. So about 67% are going to have an arrhythmia. And from there, next is going to be rhabdo at 56%, AKI, which is about 40%, hypotension, about 30%, heart failure is going to occur in about 23%. And then finally, we get all the way down to the bottom of this chart and we see that green urine occurs in 11%. So green urine is not that common in the propofol infusion syndrome. What does that green urine actually look like? So here's a picture from the University Hospital and a patient who did not have the propofol infusion syndrome, but was on propofol. And this is sort of the stereotypical picture for the green urine. So this occurs because of a phenol derivative. I don't know what that is, but a phenol derivative in propofol, which tints the urine color green. So the important thing to remember here is that this is a completely benign finding. And so having green urine doesn't predict the development of the propofol infusion syndrome. It doesn't herald any bad things. It just means the person's kidneys are appropriately metabolizing and excreting the propofol metabolite. And again, this is actually pretty rare when you consider the entire spectrum of the propofol infusion syndrome. So we've talked about the propofol infusion syndrome, but when do we actually need to start being concerned about this? What dose do we need to be concerned about? What duration do we need to be concerned about? And to answer that question, we then looked at a couple of additional studies. So this study right here by Kremer et al. Was really the first time that anyone had written about the propofol infusion syndrome. And this study came out in 2001, and it was a neurosurgical ICU population. And for this study, they essentially analyzed in a retrospective manner all patients that had developed this syndrome in their neurosurgical ICU, what dose of propofol they were on, and how long they had been on it for. Down here, you can see that as the gray bars get larger, that means that propofol infusion syndrome happened more frequently. And you can see that there's a pretty clear dividing line here between the greater than 4 and greater than 5 boxes. And so greater than 5 milligrams per kilogram per hour was associated with more propofol infusion syndrome. So what are these doses in micrograms per kilogram per minute, which is how we dose propofol at our hospitals? So the 5 dose here is associated with 83.3 micrograms per kilogram per hour. The greater than 8 dose is 133 micrograms per kilogram per minute, And the 4 dose is going to be 67 micrograms per kilogram per minute. And so what this study showed us was that if you keep the propofol infusion rate below 67 micrograms per kilogram per minute, you could theoretically decrease the incidence of the propofol infusion syndrome. The next thing the study looked at is how long were these people on propofol for? And overall, propofol infusion syndrome happened more commonly if you were on propofol for more than 48 hours. So the big takeaway from this study was greater than 48 hours of 67 micrograms per kilogram per minute of propofol was associated with development of the propofol infusion syndrome. And this is the reason why CPRS, EPIC, at all of our hospitals limit us to a 0 to 50 range when we initially order it. So it's a system designed to prevent this from happening. And overall across the country, the incidence of this is decreasing because of smart ordering, order sets, et cetera. All right, so at this point, we've talked a lot about the propofol infusion syndrome. So we just zoom back out here. Propofol, a GABA agonist, it works fast, but its big syndrome that we're really concerned about is the infusion syndrome that can cause green urine, even though that's a benign finding. More importantly, it causes a metabolic acidosis. So if you see an unexplained metabolic acidosis for your ICU patient, please consider this if they've been on propofol for an extended period of time. So finally, how do we tie all of this conference back to the Thanos Gauntlet that we talked about at the very beginning of the session? So if we scroll down, this is a gauntlet, but instead of the infinity rings, I've replaced them with the urine pictures. A bit of a stretch, but let's go through each of these one by one. So in the middle of the gauntlet here, you can see the white urine. And so this is an example of pyuria. And so pyuria associated with infections, pyelonephritis, abscess within the bladder. One of my coaches during the conference today commented that ideally there should not be 350 cc's of pus in a Foley bag before anything is done about that. The next thing up here, we've got the green urine. And so like we said, the green urine is going to be from propofol. But another thing it might be from is methylene blue, also turns the urine green. Next, we scrolled over to the cola-colored or more brown urine. And this is going to be a reflection of myoglobinuria or myoglobin in the urine. And so the most common cause here is going to be rhabdomyolysis. Next, we scrolled over to the purple urine bag. So this is one that I've never seen before, but this picture is from the New England Journal of Medicine a couple weeks ago. And so this is called PUBS or PUBS, the purple urine bag syndrome. And actually a few of our residents were familiar with this and had seen it, but this is from bacterial infections. And so the bacteria essentially break down tryptophan in the urine and it turns your urine purple. Again, a completely benign finding. It just shows that you've got an underlying bacterial infection. The most common type of bacteria to do this were Klebsiella, Pseudomonas, and E. coli. So if you see purple urine in a bag and you haven't gotten a UA or checked for a UTI, consider it. Next, we scrolled over to the red urine. This one's pretty self-explanatory, but this is hematuria. This picture here is from a patient who had 2 liters of urine in their bladder. After I placed a Foley, there was a rapid decompression. And sometimes in rapid decompressions of the bladder, the urine can go from yellow or clear to red. You can have a very sort of transient bleed, which stains the whole Foley bag red. This is, again, a benign finding that can happen with a rapid bladder decompression. And then finally, here's the orange urine. And the orange urine is going to be from rifampin. So we zoom back out here to this urine gauntlet. You can see that there are 5 different colors of urine. The only one I don't have on here is black. So if anyone ever sees black urine, please let me know. And sort of the joke I ended conference with was if you snap your fingers after wearing this gauntlet, half of the world's urologists will disappear. So overall, if we zoom back out, you can see today we talked about the cannabinoid or cannabis hyperemesis syndrome, something we see a fair amount in Denver. We then walked through a pretty good case of propofol infusion syndrome, presenting with an unexplained metabolic acidosis and arrhythmia. We talked about why propofol infusion syndrome happens and what safeguards are in place to prevent us from doing that for our patients in the ICU. And then we ended the case by talking about the urine gauntlet and the various types of urine colors and what they mean in clinical practice. So thank you all for watching and have a great day.